So first I invite Dr. Shruti to present association of LOX-L1 gene and serum folate levels in pseudoexfoliation syndrome and pseudoexfoliation glaucoma in South Indian population.
I'll start, sir.
Yes.
Hello everyone, this is Dr. Shruti from Chennai, and my presentation is on association of LOX-L1 gene and serum folate levels in PXFS and PXFG in South Indian population. So genetic predisposition, particularly mutations in LOX-L1 gene, is strongly associated with PXF and PXFG. So these mutations have reduced enzymatic activity, which impair the elastogenesis and promote the accumulation of PXF material. Folic acid is associated with homocysteine metabolism, oxidative stress and vascular dysregulation, which contributes to the PXF pathogenesis. So the objective of this study is to determine the genotypic frequencies and association of single nucleotide polymorphisms of the LOX-L1 gene, namely the RS10486661 and RS3825942 with XFS and XFG in South Indians, and also to determine the concentration of serum folic acid levels in XFS and XFG, and to analyze the association between the LOX-L1 gene and serum folic acid in patients with XFS and XFG in South Indians. So it was a prospective interventional case control study which had a sample size of 30 with XFS, 10 with XFG and 40 age-matched controls. And patients with any ocular morbidity or taking any vitamin supplements and folic acid were excluded. The chromosomal DNA was segregated from the blood samples and serum folic acid estimation was done using the immunoassay. And statistical analysis was entered in 26.0 software. So this is the demographics where you can divide the groups either into 2 or 3. When dividing the groups into 2, you had the study group which comprised of the XFS and XFG patients and the control group which had only the age-matched controls. And this can also be further categorized into 2 subtypes, the XFS separately and the XFG and the control group. So this slide, it depicts the association between the 2 groups and genotypes of the SNP RS10486661, which showed that the genotype TT was significantly more and the TG was less in the study group when compared to the controls, and GG had no significant differences. While comparing the association between the 2 groups and genotypes of the SNP RS3825942, there was no significant difference in the association. And on association between the 3 groups and genotypes of SNP RS10486661, we found that the TG genotype was more in the XFS than compared to the controls, and GG was significantly less in XFS and XFG. While comparing the median values of serum folic acid with XFS, we found that they were higher in the control group. So this implied serum folic acid levels were associated with XFS, and this can be useful in screening and monitoring the exfoliation syndrome. While comparing the median values of serum folic acid of the 2 groups with genotypes of both SNP, it revealed that only the RS3825942 single nucleotide polymorphism had a significant association with serum folic acid levels in the study group. While comparing the median values of serum folic acid levels between the genotypes of the LOX-L1 in the SNP of 3825942, we found that the TT and the TG genotype had significant differences between the median values of serum folic acid amongst the study group. So which implied the low levels of serum folic acid had a presence of heterozygous genotype, which is TG, and higher levels of serum folic acid had the TT genotype amongst the study group. So thus, to infer, we found that the serum folic acid levels were significantly less in the XFS and XFG patients, and the LOX-L1 RS3825942, the TG genotype, had a lesser value of serum folic acid levels than that of the TT genotype. And similarly, the lower serum folic acid levels in the population with the XFS indicates a higher chance of presence of LOX-L1 RS3825942, the TG genotype. On discussion, the meta-analysis of published studies in multiple populations implicated the RS3825942 as a main disease-associated SNP and XFG. However, in this study, we found that the homozygous dominant genotype of the RS10486661 and the genotype of the RS3825942 had a positive association in the XFS and XFG patients. The greater deficiency was observed in the South Indian cohort, which can be due to the regional dietary habits low in folate-rich foods. So thus, studies with larger sample size across diverse populations and considering all the confounding risk factors to be considered to draw safe conclusions in the future. So to conclude, this is the first study to find an association between the LOXL1 gene mutation, single nucleotide polymorphism and serum folic acid levels in Indian population. So on future directions, we have to consider the genetic screening, nutritional interventions, integrating both the profiles and examining the combined impact of genetic and nutritional factors on disease progression and provide insights into therapeutic strategies. Thank you.
Did you check for any homocysteine levels in your patients? Because folic acid levels are always linked with the homocysteine, and that could be a contributory factor as well to pseudoexfoliation glaucoma. That is the latest concept.
Yes,
So we should have done.
We didn't do the homocysteine.
Yeah,
levels.
because folic acid levels could be any dietary influences and all that as well.
Any clinical significance in routine life? In the meantime, I'll invite Dr. Kirti Singh if she is there. If she is not there, then I'll invite Dr. Shifra Burman to be on the podium on the other side. Any clinical significance of this?
So here, instead of doing the study was just like to determine if there is any association between the genetic mutation and the serum folic acid levels. Instead of running this patient's blood sample on the genetic analysis, we can just find that the serum folic acid level is low, and then retrospectively we can just analyze whether that genotype is particularly involved or not. So.
Do you feel that folic acid supplementation is really going to help? That's what is the actual significance here? Okay.
Thank you.
Thank you.
Please start.
Good afternoon, everyone. To begin with my presentation, first of all, I would like to show the fundus photo of a patient. This fundus photo shows that it may be a fundus of a disc suspect patient. So we usually go for a perimetry. Here the perimetry of the right eye shows that high false positive error, and the perimetry of the left eye shows a high false negative error. Then we may go for OCT RNFL, whereas the OCT RNFL is absolutely normal. So from this, the thing that comes to our mind that there might be something which affects the performance of the visual field. So here
Hall manager, please check the
so
timer.
here is my presentation.
Just wait. This timer is...
No, it's going there, sir.
No, that's going on the slides, but this timer, either it should be switched or it should function properly. I think we'll have to restart this talk. Please start again. Thank you. Timer also set again.
The slide timer to be made 5 minutes.
5 minutes. It's 5 minutes talks, no?
Yeah.
5 minutes.
5 minutes talk.
5 minutes.
Ma'am, you can start from.
Hall people, please make it 5 minutes. Yes, please start.
Good afternoon, everyone. To begin with my presentation, before that I would like to show the fundus photo of a patient of a disc suspect. So by seeing this type of the fundus photo, we may go for visual field analysis. So here the visual field analysis of the right eye showing the high positive error, and whereas the left eye perimetry shows a high false negative error. Then we might go for a OCT RNFL. The OCT RNFL shows that both the side it is normal. So from this, the thing that come to our mind that there might be something that affects the performance of the visual field. So here is my presentation, that is a study of anxiety in patients with perimetry in primary open-angle glaucoma undergoing automated perimetry. As you all know, glaucoma is a chronic progressive optic neuropathy characterized by structural and functional damage. The functional damage and the progression of the disease are best assessed using perimetry. The visual field assessment is also affected by the patient's psychological status, and the anxiety can reduce focus during the visual field assessment that could affect the accuracy of the test. So the goal of my study is to determine how anxiety impacts the visual field accuracy in primary open-angle glaucoma. So prospective observational study of 53 patients were taken up in a tertiary care hospital for a period of 12 months with patients with primary open-angle glaucoma after satisfying the inclusion and exclusion criteria. The tools that are required informed consent from the patient, MOCA questionnaires, state trade anxiety inventory forms Y1 and Y2, and the Humphrey visual field analyzer, Carl Chase Meditech were taken. The patient with primary open-angle glaucoma above 40 years of age are included in this study, And the patient who has having the history of use of steroid in the last 6 months, those who are having history of trauma, ocular surgery, or visual acuity less than 6/60, having history of chronic uveitis, evidence of pseudoexfoliation, pigment dispersion, having hypermature intumescent cataract, and those are already having pre-existing anxiety disorders or depression and are on psychotropic medication are excluded from the study. After fulfilling the inclusion and exclusion criteria, the patient undergoes through the basic ocular examinations, and they had to, after that, they had to do the MOCA questionnaire form to rule out the anxiety disorders. Those who have scored above 26 out of 30, they were our final samples. And then they have to go through another questionnaire, which is STAI form Y2, which calculates the intertest anxiety. Immediately after completion of the test or in between the test, they have to undergo through another form, that is Y1 form, which measures the intertest anxiety. After completing the test, they do the post-test questionnaire, which describes the test as anxious, difficult, tiring, long, uncomfortable, or unpleasant. So after collection of the data, we undergo through the statistical analysis. In this, the statistical software IBM SPSS version 19 were used. The result showed that the patient who had undergone more number of the test has less pre-test and intertest anxiety. And intertest anxiety is 1.11 times higher than that of the pre-test anxiety, with a p-value of 0.0001. And the reliability indices like the false positive, false negative, and the fixation losses were improved by performing the more number of the test. So in our study, we found that the intertest anxiety is 1.11 times higher than that of the pre-test anxiety, and patient who had undergone more number of perimetry had a significant lower pre-test and intertest anxiety than those who had not. Kalia Penumal, Suhasini, and Janani V.S. et al. Reported that automated perimetry induces anxiety, which may affect the test performance. The measured anxiety reduces as the patient gains familiarity with the test with experience. Shenton Esolshio and Nathan M. Kerr et al. In their study stated that increased anxiety, pre-test anxiety may reduce the HBF test reliability. So to conclude, the automated perimetry induces anxiety, and this has an impact on the test reliability. Patients with considerable experiences of the test procedure are less anxious, showing the scope for improving the test reliability through decreased anxiety. The clinicians therefore should acknowledge this anxiety with the patient and make attempts to reduce it in order to improve the patient experience and test reliability. These are my references. Thank you.
So can the next speaker come on the stage in the meanwhile? Dr. Muralidhar?
Dr. Shipra,
Yes.
Out of this study, after having seen this study and so much of anxiety, do you think, would you like to recommend that patients should be given some anxiolytic drugs before the test in case they have some, in case the tests are not found reliable?
No, sir, we should not give anxiolytic. We should counsel the patient properly, and we should make some, in our institution, as we have made that video demonstration of the test, we counsel the patient properly. After that, we tell the patient to perform the test by talking, by counseling them.
See, whenever we are doing automated perimetry, it's a well-known fact that we do not take the first this thing into consideration. We always do say 2 or 3 tests before we consider it as reliable. And always, if you do a proper pre-counseling of the patient and you already know false positive, negatives, gaze tracking is going on, so the process of going through these tests prior to that, especially in a busy setup, how it will be clinically relevant to us?
Ma'am, when we counsel the patient and when the patient performs the more number of the tests, the anxiety automatically reduces.
Yeah, so the reliability of the field increases, and that is what I said, we take the second or third field whenever we are doing any glaucoma diagnosis.
Yes,
So we're already subjecting him to 2 further tests, and then that itself might add to his anxiety.
Okay, thank you.
thank you.
Thank you, everyone. My free paper is on optimally utilizing the stenting suture for aqueous drainage devices in glaucoma. So as we all know, glaucoma drainage devices are used in refractory glaucoma, and non-wall drainage devices would function only after the ligature suture dissolves. Sometimes at dissolution, there can be a precipitous IOP drop, which could trigger hypotony, and delayed hypotony has also been reported with non-wall glaucoma drainage devices. So hence came the stenting suture. We use the 4-0-proline suture. 3-0-supramid has also been described. It offers continued resistance after the ligature suture dissolves. Partial removal, which I will describe in the slides to come, may be effective while retaining the benefits of the stenting suture in place. This is how the stenting suture is placed. This is the ACP250 device. So the ligature is tied over the stenting suture. Sometimes you may have exposure of the suture which may require removal, and there could be a suture track leak. So the stenting suture is buried 2 quadrants away. So this is what I mean by partial removal. Please note there is a ligature suture here. So you pull the stenting suture just past the ligature sutures. So you can see the tip of the stenting suture has come just past the ligature suture, so which is indicated by the arrow. So the ligature suture is still within the lumen of the tube. The stenting suture is still within the lumen of the tube and the ligature is in place. So this allows a partial flow through the non-wall glaucoma drainage device. So study question was, does partial or complete withdrawal reliably reduce the intraocular pressure in emergencies? Could there be any complications, and what is the optimal time for a partial removal? So could it be 3 weeks for 250 millimeter square and 4 weeks for a 350 millimeter square device? So the inclusion criteria: patients with refractory uveitic silicone oil induced neovascular glaucoma underwent GDD implantation, and an informed consent was taken from all patients, and all of them underwent a comprehensive ocular examination. So surgery was done by a single surgeon, standard technique, a patch-free aqueous drainage implantation. The ACP250, RD250 and the RD350 were used. Surgery was done under subtenance anesthesia. Venting slits were used in all patients and the stenting suture was buried 2 quadrants away. We used the 4-0-proline in all our patients. Postoperative review was timed in the first day, first week, third week and fourth week, and subsequent reviews at the examiner's discretion. So standard regime was 1 week of topical antibiotic and a tapering regime of topical loteprednol. Anti-glaucoma was used for 42 days and with cycloplegic commencing from day 35. This was the routine for all patients with GDT. For those who underwent withdrawal, for partial withdrawal, which was done at 3 weeks for 250 millimeter and 4 weeks for 350 millimeter square devices. So partial withdrawal was done when the IOP was uncontrolled on maximum medical therapy with advanced glaucomatous damage, where it was believed that visual loss is imminent if some action is not taken, or when there was excruciating pain or severe corneal edema because of a raised IOP. And cycloplegics were commenced and the AGM was stopped. So complete withdrawal was done for exposure and in 1 patient for an uncontrolled IOP at 2 months, and cycloplegics were commenced thereafter. So we had 12 patients. I mean, these were the 12 patients who underwent some kind of a withdrawal, either partial or complete withdrawal, with a mean age of 50.2 and 4.6 years, and with maximum medical therapy, 6 of neovascular glaucoma, 4 of silicone oil induced glaucoma, and 2 with refractory glaucoma, equally divided between ACP and RD250. So if you notice the figure, this is the figure taken after the stenting suture partial withdrawal. You can see the stenting suture just past the ligature sutures. So for exposures, a complete removal was done. As I mentioned, 1 patient we had done a removal because the IOP was uncontrolled at 2 months. And the first partial withdrawal that we did had an accidental removal which was done under topical. Subsequent were done under subtenance anesthesia. The rest, the IOP substantially reduced. In 1 patient, it reduced only to 32 from 54, and this patient had an additional drop at 6 weeks. And this was the patient who underwent rerouting, past planar rerouting for exposure. 1 had a transient suture leak, and in partial removal, the suture position was confirmed. So this was the patient who underwent rerouting along with partial suture withdrawal, and so you can see that the suture has come just past the ligature. So stenting suture does reduce the chances of hypotony. That's a known fact. An early partial removal has been described. I have included the reference here, but the literature on efficacy, the optimum timing is not there. Non-wall devices can cause IOP, delayed IOP drop, but this can be partially offset by withdrawing the suture, and possibly it is effective only prior to the maturation of the capsule, and late removal may not be of value. The other potential options that you have include laser sutural lysis of the ligature, removal of 1 if you have used multiple stenting sutures, and not ligating but allowing partial flow through 2 stenting sutures. So the implication is that partial suture removal can negate the disadvantage of a delayed IOP drop, or a 2-stage implantation can be considered at 3 weeks. And the concerns, of course, small number of patients and suture track leaks. We don't know the impact on hypertensive phase or accidental complete removal. And so intraoperative planned placement of ligature suture, strategic placement would facilitate this maneuver. So we can try this in dire situation and to be considered on an individual basis and not routinely for all patients. Thank you. Thank you.
Professor Kirti, can you take the?
Could you tell us how useful this information could be just from 4 cases, because 6 patients you have taken and out of which
No, sir,
2 could not
actually,
be done a part
yes,
of study?
So in the same period of the study, we had done 25, of which 12 patients required some kind of a removal of this stenting suture. And one, it had to be removed because the suture had got exposed, which had included the photograph. In the other patient, at 2 months, the IOP was uncontrolled, so we removed it completely. There was no ligature. For the remaining 9 patients, actually, so this partial suture removal was of a very great value because the pressure was like 40 plus, and either the patient had imminent vision drop or the patient had severe excruciating pain. So we withdrew it just past the ligature suture under subtenance because this is a very fine maneuver. If you pull it a little more, it will come out of the tube, and the very purpose of putting a stenting suture would be defeated. So we want the stenting suture inside the lumen, but we want it just past the ligature so some flow can start. So in all these 9 patients, I believe, sir, either it prevented imminent vision loss or relieved excruciating pain for these patients, because till 3 months they were on 5 AGMs and we added Diamox glycerol, still the pressure was above 40. So when we partially withdrew it, we retained the advantage. None of these patients had any hypotony, these 9 patients. But in all, we prevented an imminent vision loss.
So in that patient in which you completely removed the stenting suture,
Yes, ma'am.
so what was your IOP in the follow-up?
Yeah, madam. So actually, that patient, that was the first that we attempted a partial removal. We did it under topical anesthesia. So patient jerked the head and it came out of the lumen. So immediately the pressure precipitously dropped to 2. Fortunately, this patient did not have any suprachoroidal or anything, but had serous choroidal detachment, which subsided over 2 weeks, and the pressure went back to 12 or 14. But in the rest, we have done under subtenance with a traction suture in place. And in all those 9 patients, we just withdrew it past the ligature.
Why not to do walled implants in this kind of severe
Sir, the
cases?
disadvantage of walled implants is that the target IOP that is achieved, because the capsule is exposed to inflammatory mediators right from the start of surgery. So the target IOP that is achieved with walled implants is more actually. The IOP that is, it doesn't achieve the target IOP, and the success rate is less with walled implants. The other thing is walled implants are more expensive, sir. Like Ahmed wall comes at 28,000 a piece, whereas the RD250 is only 4,000. So.
So all the 25 you said were included in this particular study?
Actually, I have presented data only for the 12. For the remaining 25, the situation was not dire. So we did not attempt any partial removal. We left the ligature to dissolve on its own. Only for the 12 out of the 25 had some kind of a withdrawal, which was almost 50%.
What exactly was the cutoff limit for the IOP for?
Yeah, sir, if it is patient with advanced glaucoma, glaucomatous damage and more than 35, or patients with excruciating pain and IOP again more than 35 was what we used as cutoff on maximum medical therapy, including Diamox and glycerol.
Okay, thank you. Thank you so much. Dr. Kirti Singh, please start.
Thank you. My paper would be intraocular pressure and retinal circulation alterations in pregnancy with preeclampsia, no financial interests. Now we do know that pregnancy, especially preeclampsia, stated as PET from now on, and eclampsia impact both the intraocular pressure and ocular perfusion pressure. Now this has a relevance for patients with pre-existing glaucoma and for prognosticating the hypertensive pregnancy cases post-labor. Because of increasing age of pregnancy and the altered physiology and impending pathology, this is of relevance. And for prognosticating hypertensive pregnancy, we need constant vigilance. So very little work has been done globally on these select group of patients. So we had a cross-sectional comparative study with the Department of Ophthalmology and Obstetrics, and 80 patients were taken. Pregnant patients aged 18 to 40 years with a period of gestation of more or equal to 20 weeks, with the best correct visual acuity of more than 20/40, with a clear ocular media because OCTA had to be done. The cases were the patients diagnosed as preeclampsia, and the controls were healthy age-matched pregnant patients. Excluded were the chronic hypertension, systemic comorbidities, and conditions which would impact the vascular factors. The refractive error, high refractive error, and prior ocular surgeries and smokers were also excluded. The parameters assessed were obviously the best visual acuity, the intraocular pressure, fundus examination, central corneal thickness, and the mean ocular perfusion pressure, or the MOP, and also the mean arterial pressure. The octa was done by the Cirrus machine with a minimal signal strength of 6 was taken and the foveal avascular zone was measured, the superficial vessel density, foveal, parafoveal and peripapillary retinal nerve fiber thickness. In addition, radial peripapillary capillary vessel density was measured. So what did we find? That for the similar pregnancy age, the MAP, obviously the mean arterial pressure was higher in the preeclampsia, that's a no-brainer, but the intraocular pressure was also higher, although that was not significant, but the corrected intraocular pressure was significantly higher in the preeclampsia, and the mean ocular perfusion pressure also was significantly more in the preeclampsia. The foveal avascular zone, all these pictures are showing the foveal and the parafoveal, superior, temporal, inferior and nasal. The difference from the normal pregnancy was not significant. This is the radial peripapillary capillary vessel density. Now this was very significant in the preeclampsia cases, the vessel density was more. Retinal nerve fiber thickness was similar. So this is a brief video showing how the octa was done. And remember, these were all pregnant patients who had been brought from the obstetric department. And we had measured them with dilated examination of the fundus. So this is a virtually non-edited video of how the foveal avascular zone and the other areas were measured by the octa. So this is one of the cases where the superficial capillary plexus in preeclampsia was measured, and this is another one for the peripapillary nerve vessel density. And as I said, the retinal nerve fibers were similar. So what did we find? That IOP and corrected IOP was significantly more in preeclampsia vis-a-vis normal pregnancy. We know that in normal pregnancy, there's almost a 10% reduction in IOP due to increased outflow facility. So something is different in preeclampsia because of increased BP. Maybe the aqueous secretion is more or the outflow facility is less. Ocular perfusion also was significantly more in preeclampsia, which would be because of both the systolic and diastolic pressures counteracted the increased intraocular pressure. Retinal nerve fiber thickness was similar to normal pregnancy because there was no retinal edema, so probably eclampsia it would not be. But the macular vasculature was preserved, the foveal avascular zone was undisturbed, optic nerve head perfusion, especially the radial peripapillary capillary vessel density was significantly more, and probably only one patient had disc edema also, so probably that the optic nerve perfusion is undergoing a change. Limitations of a study, cross-sectional postpartum follow-up was not there and severe eclampsia was excluded. Strengths, case control, both octa and MOP was done, adequate sample size. It demonstrates increased IOP and more in the ocular perfusion and retinal vascular changes despite a normal clinical fundus, which means autoregulatory mechanism of retinal vasculature supersede and give a normal retinal flow at macula, but the optic nerve head is much more vulnerable. Implications are that increasing maternal age because of different problems, because of physiological stage of pregnancy does result in altered ocular hemodynamic alteration, and we need to look at this more significantly because of the female population, especially those who have pre-existing glaucoma. Thank you.
Kirti, could you show us the slide of exclusion criteria once again, please?
Yeah, here.
You have written obstetric conditions other than pre-eclampsia.
Like gestational diabetes and twin pregnancies, because twin pregnancies are supposed to impact the ocular perfusion more.
See, once the inclusion criteria is pre-eclampsia, the other things automatically get excluded. So probably this was not required.
Actually, twin pregnancy and eclampsia can go together, and so can gestational, so we had mentioned this. Therefore,
Okay. So what is the clinical implication of this study?
yeah, exactly what I said at the last, that we are facing now that increasing maternal age and preeclampsia happens in 7 to 10% of pregnancies. So we are looking at altered hemodynamics in these patients, And especially if they are diagnosed glaucoma, it would be much worse. We have not studied the diagnosed glaucoma cases, but it would be much worse. And since Octa is now available, we can have a look at the hemodynamic alterations, because that would have implications on the visual field changes and the long-term prognostication, because we are right now saying that it is altered. Would it come back to normal after labor? We need to know, and there are not many studies on this. And most of the ladies would become pregnant, and out of them 5 to 10% would have preeclampsia. So it's a huge number we are looking at, which we need to check. So that's the clinical implications.
Yeah. But the RNFL, you said there was not much of difference.
No, RNFL, ma'am, wasn't, because there was no vasogenic edema. So RNFL thickness, these are all healthy young patients. They were not glaucoma patients. So they have a normal RNFL, and if there's an edema, vasogenic edema, then we would have expected the RNFL to be thicker, and that could have complicated the issue, but that was not there in this patient.
Ma'am, the IUP difference in that slide you showed was not clinically significant. It was a
No,
corrected.
it wasn't. It wasn't clinically significant, but it was higher than the ones which is there in normal pregnancy.
So was
Like-
there a difference in the
and they
corneal thickness?
corrected-
Corneal thickness
Yes.
in between these two groups?
Very pertinent. If you can see the corneal thickness again, it wasn't very significant as is evident, but when you did the corrected IOP measurements after the corneal thickness, it became significant. So although there was not much corneal edema, but definitely the corneal things have changed, and the IOP after correction became significant. And this is again more important, because normal pregnancy IOP reduces. And now in preeclampsia, eclampsia it would be much worse. Preeclampsia, it is increasing. So IOP is increasing, and the vascular perfusion is also being impeded. So we need to look at these more vigilantly now, and this is a huge population which it's a silent population which we are not looking at.
Okay, ma'am. Thank you.
Thank you. Thank
Can
you,
I
Dr.
make
Kirti.
just small comment? Is there any going to be association of anemia and pregnancy? Will this affect our study?
Ma'am, very beautiful question. But we had ruled out anemia. Exclusion में नहीं लिखा है हमने, but all these patients were healthy, who had passed the antenatal check, and everything was healthy, and the control group was also healthy, and these were, other than preeclampsia, other things were not there. But yes, very pertinent.
Thank you.
Thank you for a very nice, I think, study.
Dr. Muralidhar, please.
Muralidhar,
Sorry.
presenter.
Next is
Indu? Dr. Indu
Indu.
Pavani.
Achha, Muralidhar has all.
He is already presented. He is already presented. So, Dr. Indu, start, please.
Good afternoon, everyone. Today I'll be presenting on the topic titled LTPP2 related congenital megalocornea with zonular weakness and secondary lens related glaucoma. So the objectives of this study are to understand the distinct ocular phenotype and to understand the phenotypico-genetic correlation of the LTPP2 mutations, and to emphasize on the role of early and appropriate management of children with these mutations. So the inclusion criteria are megalocornea without HAP striae, iridonosis, and with subluxation or dislocation of the crystalline lens, along with whitish appearance of the pupillary margin or ectropia and uvea. Exclusion criteria are classic primary congenital glaucoma with HAP striae, other systemic syndromes associated with ectopia lentis, secondary glaucoma due to posterior segment pathology, congenital megalocornea, and keratoglobus. This cohort included a total of 18 children born from 14 consanguineous families with age group range from 4 months to 12 years, and majority of them were male. Children underwent detailed anterior segment examination, measurement of intraocular pressure, along with optic disc and peripheral retinal evaluation. Out of the 18 children, 14 children were diagnosed and referred from elsewhere as primary congenital glaucoma or ectopia lentis or PCG with ectopia lentis. And out of them, 4 eyes underwent pars plana lensectomy and vitrectomy, and 2 eyes underwent combined trabeculotomy and trabeculectomy. So this is the most important slide of the presentation, where you can see the typical phenotypic features of megalocornea, gross iridonosis, and ectopia lentis in all eyes. And persistent pupillary membrane was present in most of the eyes. The other eyes had ectropia and uvea, or combination of persistent pupillary membrane or ectropia and uvea. And almost 50% of them had coexisting retinal pathologies. When we are doing vitrectomy, we have noticed that they have either peripheral lattice or peripheral pigmentary changes without lattice. Of the 4 eyes which underwent pars plana lensectomy and vitrectomy elsewhere, 1 eye developed retinal detachment. And out of the 2 eyes which underwent combined trabeculotomy and trabeculectomy elsewhere, 1 eye developed suprachoroidal hemorrhage and other eye developed retinal detachment. So it is important to treat these peripheral retinal degenerations while doing lensectomy and vitrectomy to prevent retinal detachment. Secondary glaucoma is present in almost 70% of the eyes, and majority of them on topical anti-glaucoma medications. Mean age at lensectomy was 4 years, the youngest was 4 months and oldest was 12 years. And post-lensectomy, 2 eyes developed retinal detachment. Almost 65% of them had glaucoma, and half of them required glaucoma surgery like angle surgery, glaucoma drainage device, and TSCPC. One important thing which we found in our study were children who underwent lensectomy earlier than 2 years of age did not require any anti-glaucoma medication or additional glaucoma filtering surgery. And we have found that increasing age at lensectomy was associated with development of glaucoma with hazard ratio of 1.69. All children underwent whole exome sequencing along with Sanger validation. Targeted Sanger sequencing was done for the siblings and when parental segregation was needed. These are the various known mutations of LTPP2 which were published in the literature. All the LTPP2 genetic variations which we found in our cohort were novel, and all of them were homozygous except 2 siblings in one family which was compound heterozygous. And we have found 12 distinct LTPP2 genetic variant locations on LTPP2 protein domain structure, and almost half of them are in the calcium binding epidermal growth factor like domain. So LTPP2 is latent transforming growth factor beta binding to protein which maps to chromosome 14, and it is structurally and functionally homologous to fibrin 1 and fibrin 2. A very interesting article by Shi et al. Showed that this protein is required for longevity and not for development of zonular fibers. In the picture A and B, they have compared the development of ectopia lentis in wild type LTPP2 where LTPP2 gene was present, and the LTPP2 null mice where the LTPP2 gene was absent. You can see in the picture when they have taken OCT of the serial anterior segment, you can see that there is progressive displacement of the lens along with progressive flattening of the iris. And this ectopia lentis was noticed at 4 to 5 months of age, which is similar to a cohort where we have seen the youngest child was about 4 months. To summarize, this genetically proven series of LTPP2 shows that it has a distinct ocular phenotype of megalocornea without HAB striae, iridodonesis, ectopia lentis, pupillary margin changes like persistent pupillary membrane or ectropion UVA, secondary glaucoma, and peripheral retinal degeneration. Genetic counseling and early sibling screening and prompt execution of the lensectomy is needed, as any delay in treatment will lead to refractory secondary glaucoma. And it is important to differentiate this condition from primary congenital glaucoma, as any primary glaucoma surgery will lead to a devastating complication like suprachoroidal hemorrhage leading to phthisis. Diligent peripheral retinal examination is important, and it is important to treat them during parspinal lensectomy and vitrectomy to prevent retinal detachment. Thank you.
Thank you so much. And most of the children, the parents had consanguineous marriage.
Yes.
Any reason for this? Or any inclusion criteria which resulted in this kind of a selected population, or is it because of the genetic?
The patients were presented, and when we went to the history, they had consanguineous marriage.
So this kind of an issue is very unlikely in non-consanguineous marriage.
But in South India, consanguineous marriages are common, where we see the population.
So basically, it has an autosomal recessive pattern. So therefore, in consanguinity, obviously, there are more chances it will express itself. So how did you...
this is the answer I expected.
Okay.
So how did you clinically distinguish it from, like you said, congenital glaucoma? It's a 4-month child who has come to you.
So primary congenital glaucoma will have HAB striae. That is one important differentiating factor, and they don't have ectopia lentis in primary congenital glaucoma.
And what about Marfan syndrome?
The Marfan syndrome has ectopia lentis, same, but they don't have megalocornea.
Like it's a 4-month.
I know,
sometimes you could have
if they have secondary
or
glaucoma,
spherophakia even in Marfan's.
If they have associated secondary glaucoma, they can have megalocornea.
What is the pattern of inheritance of Marfan's?
Marfan's is autosomal dominant. This is autosomal recessive.
So if the child has come and it's a 4-month child, look at the parents, look at the siblings as well.
And what age are you suggesting lensectomy?
As soon as we see the child, we have to do lensectomy, because we have seen that children who underwent lensectomy less than 2 years, they didn't require any anti-glaucoma medications or additional glaucoma filtering surgery. So we advise lensectomy as soon as we see the child.
So 4-month-old child, go ahead and do it.
Next, Dr. Usha, please continue.
Good morning Good afternoon to one and all. Today, my paper is bringing virtual reality to real world, comparing VR perimetry with standard automated perimetry. Glaucoma-related blindness is estimated to increase to 112 million by the year 2040. If you look at the prevalence of undetected glaucoma, there are 44 million cases globally, out of which 77% of them are estimated to be prevalent in low HDI countries of Asia and Africa. These numbers stress that we need to strengthen our screening strategies. Standard automated perimetry has remained gold standard for glaucoma screening. However, it has its own drawbacks, like bulky setup, requiring dark room, and poor patient attention. Evolution of technique is definitely the need of the hour. In this study, we have used Smart System Virtual Reality headset. It comes with an SSVR headset and a hand trigger by which the patient gives the response, and this is paired with a Microsoft tab. Our study objectives were to analyze the sensitivity and specificity of this novel SSVR headset perimetry compared to standard one, to assess the performance in mild, moderate, and severe glaucoma groups, and also to look at the patient feedback about both these techniques. We included all the glaucoma patients aged between 80 to 70 years with best corrected visual acuity of 618 or better, and who are able to perform visual fields reliably. We excluded all those who had undergone surgery in the recent past, and extremes of refractive error, plus or minus 5 diopter, were also excluded. Controls were also belonging to the same age group who were able to perform visual fields reliably without any media opacities which could bias the diagnosis. Coming to methodology, we had 362 eyes of 222 patients in cases and 151 eyes in the control group. Baseline ocular examination was performed as shown in the image. These patients were subjected to undergo standard automated perimetry and VR perimetry in random order with a 10-minute resting period on the same day. Patient feedback was obtained at the end of the procedure. Coming to the results, glaucoma patients were found to be older as compared to controls. If you look at the mild group here, we had 160 eyes. We found that fixation losses and false negatives were significantly lower in the VR perimetry group. False positives were found to be higher, and test duration was in fact found to be longer in the VR perimetry group. We saw the similar trend in the moderate glaucoma group as well. In this group, we had 103 patients. In the severe glaucoma group, we had 99 patients. Again, there was a trend of lesser fixation losses and false negatives. In addition, there were significantly better threshold sensitivity in the VR perimetry group when it came to severe glaucoma. These were some certain samples which is obtained from standard automated perimetry and VR perimetry. This is moderate glaucoma and this is severe glaucoma. This VR headset is testing 60 points in 4 quadrants, and in addition there are 4 central points closer to fixation. This is the ROC curve analysis which showed that the 24-2Z strategy was a good technique, especially in estimating mild and severe glaucoma. We also did a scatter plot analysis to look at the mean deviation values of VR perimetry versus standard automated perimetry, and there was a very good correlation. The bland Altman plot showed that majority of the readings were within the 95% confidence interval range. When we look at the patient feedback, 66% of them felt that the VR perimetry was easier to perform. 40% of them felt that it was ergonomically more comfortable, and 38%, if at all given a choice, wanted to go with VR perimetry as compared to 53% who gave an equivocal response. Ocular discomfort was slightly higher in the HFA group. Coming to discussion, this prototype of CFA device this CFA device was used, and here supra-threshold strategy was utilized. The ROC curve here was higher for the severe glaucoma group as compared to moderate and severe. This is another study where Gear Vision headset was used, and here the fixation losses was much higher as in contrast to our study. The false positive response rates were higher. Threshold sensitivities with Gear Vision was significantly higher than that with HFA, and this was in fact attributed to the non-occlusion of the fellow eye, which is in fact a more physiological way of testing visual fields. VR perimetry is in the market for quite some time now, so what new thing are we bringing to the table? This is a prospective study, and to best of our knowledge has the largest sample study recruited so far. There is real-time tracking of patients' performance. Z strategy is being utilized, and we can see that there is definite evolution of technology, which started off as a supra-threshold yes or no, pass or fail test, has become very much comparable to standard automated perimetry. What were the drawbacks which we saw? Time taken to complete was slightly longer because the VR perimetry was pausing the test until the patient regains the fixation. There was no clear superiority of VR perimetry over standard automated perimetry. Now, what is my take-home message? VR perimetry should be used as an effective bridging tool to strengthen glaucoma screening, especially in crowded OPDs, in outreach and vision center settings, targeting high-risk patients, and also in using home screening for vulnerable patients. Thank you.
Thank you. See, the only concern in this, from this study which comes to my mind is that there are a lot of false positives in the VR study.
Yes, sir.
And false positives, although when we technically say, the machine says they are taken as equivalent to false negative, but in the practical sense, false positive are far more important than false negatives or even fixation losses.
Correct, sir.
So that makes this instrument much less reliable to me from your study.
Yes, sir. The reason for this is the technique by which the machine is estimated the false positive, sir. The machine is, the way the Humphreys is estimating is slightly different. So there is yes or no test. But here, what the device or VR headset is doing is that if at all the patient is responding very quickly, if the minimum response time is very fast, that way it is counting it as a false positive. So basically,
so do you think the false positives coming in this machine are less significant than the false positives coming in Humphrey field? Do you mean that?
the other way of saying it is this machine is very sensitive to patients' false positive responses. So that should be worked upon before we bring it to the market, definitely. I agree, sir.
You said it takes more time.
Yes, sir.
And you also said it can be used for screening.
Yes, sir.
So how does that call?
The reason why this was taking longer time was the VR headset
No,
is
I understand. I understand that.
it is pausing the test in between, sir.
No.
whenever there is fixation.
When a screening test should be
Faster.
faster.
Agreed.
So
Agreed.
how can
Then
One
how
more
are
thing
we
is-
monitoring the gaze tracking? How are we doing the gaze tracking in this?
Gaze tracking with the CCTV, it can see how the patient is moving the eyes, and it can fall with the.
So we need somebody to monitor even on this device.
Yes, madam. The tab which is there can monitor the patient's performance in real time.
Okay, thank you.
Thank you.
Dr. Ankit Shah, please.
Good afternoon, all.
Is Dr. Shraddha Raj present now? He was absent in the beginning. Not present even now? Okay. Please go ahead.
Good afternoon. So my paper is artificial intelligence to predict the sensitivity of the diagnostic parameters for the early glaucoma. So many times early glaucoma pose a unique set of challenge. So many times the IOP is borderline, disc changes are not clear cut. Even the patient is not able to do the perimetry properly, or even the OCT is showing some equivocal changes. So many times the dilemma comes how we go ahead. And to add to this confusion, like initially the EMGT study mentioned that sometimes in early glaucoma there's visual field defects comes even before the structural changes appears. However, the many other studies have shown and otherwise, like structural changes usually comes before the functional changes, but this relationship is not uniform, and the measurement variability further adds to the confusion. So the objective of our study is to evaluate the diagnostic ability of the different perimetry program, 24-2, 24-2C and 10-2, along with the OCT in diagnosing the early glaucomas using with the help of the artificial intelligence, and to study the consistently altered parameters in glaucoma patients. So this is a prospective cross-sectional study and conducted in the Shingar Tertiary Eye Care Centers, and the normal and glaucoma subjects who gave their consent were included, and ethics committee approval were taken. And subjects were divided in glaucoma suspects and normals. So the patient with having the disc suspects like a high cup disc ratio or cup disc asymmetry or neuroretinal rim changes or nerve fiber layer defects, or either with the high IOP like more than 21 mm of HG on 2 occasions with the GAT, or visual field defects, or person having the primary angle closure glaucoma with the more than 180 degree of iridotrabecular contact in which the laser PI has been done. So the person presenting with one of this criteria, not fulfilling all of this criteria were included. And the exclusion is if a person is not able to perform the visual field reliably, or the OCT scan has not come properly, or any confounders like systemic or neurological comorbidities that might have confounded the visual field results were excluded. And if a person has undergone the other surgeries apart from normal cataract surgery has been also excluded, and the extremes of refractive errors were also excluded. So all the persons underwent the detailed clinical examination, and the visual field assessment was done with the 24-2 CETA standard and 10-2 CETA standard and 24-2 CETA faster program. and OCT RNFL was done using the Topcon Triton OCT RNFL and GCC analysis was done. So all these scans were done on the same day. Random eye was chosen for the first for the examination, and adequate rest was given between the tests. So the visual field data like zonal mean and standard deviation from 10 degree, 20 degree and 30 degree zone was calculated, and the other machine derived parameters like VFI, pattern standard deviation and mean deviation was included, and the OCT parameters like RNFL thickness, cup disc ratio, disc area, cup volume and GCC thickness were included. So all these parameters were put in leave one out validated random forest AI classifier, and each parameter was considered as a feature and outcome as a response. So the three modules we have designed like visual field only, visual field with OCT RNFL and visual field with OCT RNFL and GCC were included. So this so the demography is like 72 eyes of the normal subject and 271 eyes of the glaucoma suspect were included with the age of 44 and 50 years respectively, and the IOP was 14.8 and 15.38 respectively. So when we see the VF derived parameters, mean deviation and the VFI showed a difference between the glaucoma, statistical difference between glaucoma suspect and normal on 24-2 and 24-2C program. Same pattern follows when we consider the 10 degree mean and 20 and 30 degree mean also. When we see the OCT parameters, only the inferior RNFL and total RNFL shows a significant difference. When we study the modules, the VF parameters only has a AUC of 0.68, but when we include the OCT parameters, the AUC increased to 0.95 and further increased with the addition of the OCT, GCC, RNFL. And same thing, confusion matrix also, but with the VF, the high false positive rate was there, but it decreases the false positive rate when we include the OCT parameters. And when we study the top 10 rank parameters, the inferior RNFL thickness came as a first predictive parameters by the AI. So in conclusion, like both OCT 24-2 and 24-2C are effective in predicting the early glaucomas, but when we add the OCT parameters, the predictive capacity increases. But the limitation is small sample size and only South Indian population was included in our study.
So what method of AI did you use in this?
This is basically random forest AI model, and which is a leave one out validated model. So in this leave one out validated model, so for the AI training we use the first we use the test set, and then first the training set, and then we use the test set. So in leave one out validated model, each observation act as a test set, and all the other observation was considered for the training. And this process is repeated until all observations are included in the test set. Like that.
Because all these devices need to be well validated before we can come to any conclusion.
Yes, ma'am.
Thank you so much. Next, we are taking Dr. Prasanna Venkatesh Ramesh because he has another session. So please go ahead.
Thank you, sir. So this is, can I have my slides? So this is a TNOA free paper thing, comparison between two excisional goniotomy procedures, KDB versus BANG in mild glaucoma patients. So the KDB blade and the bent ab inteno goniotomy is well documented for minimally invasive glaucoma surgery, and mild to moderate POAGs were taken into this study. Primary outcomes and secondary outcomes were the reduction in IOP bottles as well as the medication-free population. Secondary outcomes were the success and the failure rates. And the World Glaucoma Association guidelines were taken into account to qualify as complete success, qualified as well as failure. And this is a prospective study which had a consenting consecutive patients during a 6-month period with 71 patients, and then a follow-up of another 6 months for them, and mild to moderate POAGs were taken based on the Humphrey or the Octopus. They were graded as mild or moderate, and based on the logistics, it was the patients who preferred whether they entered the KDB procedure or the BANG procedure, and along with phacoemulsification. It's an open label study with both the patients and the researchers aware, and the same surgeon did myself for all the procedures, and the follow-up was 1 week to 6 months. And gonioscopy and anterion was also documented in the post-operative period. So this is a surgical procedure of the KDB that was done. It was an inside-out approach, as you can see, a clockwise and an anti-clockwise movement on either side. And if there was a frill of tissue that was remaining, an ILM peeling forceps was just used to take the tissue out as a novelty. And this is a BANG procedure where a 26 gauge needle was used the same. Both inside out was technique, inside out was followed for both the procedures. Data analysis, a pair t-test was used for analysis, and the FACO KDB group analysis had an IOP drop of 22.83 to 16.25 at 6 months, and the AGM reduction was 1.16 bottles to 0.62, again only keeping mild to moderate in contention, and this was greater than 1 AGM bottle reduction, medication-free population, and the success rate being 72 complete success, failure of 13. Let's see the Bang group where a similar incident was noted, 20.28 to 15.01 with the mild spike at 1 month period, and the AGM bottles being 1.08 to 0.49 reduction in bottles, and the medication-free population of 50% at 6 months was slightly eye-catchy here, with a complete success of 48 and a failure of 26%. So let's just reboot or recompare. The path taken to the endpoint was slightly different, but more or less the drop in IOP was the same, with a 6 millimeter and a 5.27 millimeter drop in mercury between KDB and Bang. And the reduction of AGM bottles were quite same, where there was a 50% reduction of AGM. And the percentage of reduction in AGM bottles were also similar at 97 and 88. But the medication-free group was higher in the KDB group at 73 and 50 in the Bang group. And this is again the parameters of the age, the ratio, the visual acuity, and the confidence interval charting that you can see here. And complications, KDB microemphysema was noted in a few, whereas in Bang there were some patients with choroidal folds which did not have any issue with the visual acuity, and 2 patients had a peripheral anterior synechiae that you can see here. So KDB in gonioscopy and anterion after 1 month to 6 months, there was a clear W sign that was noted with KDB, whereas with Bang there was some remnants of trabecular meshwork. Both the procedures reduced the IOP and the need for AGM in patients with mild to moderate glaucoma. But patients in KDB was performed, the IOP was comparable again, while the decrease in the number of AGMs was also comparable in both groups. The percentage of medication-free patients were quite higher in the Bang group. And the complete success rate of Bang remained higher than that of KDB, because the failure rate was quite high in the Bang group, and it was twice the high as the KDB group. Whereas the Bang group showed only a 48% compared to the 72%. And this one particular animation theory was one theory that I wanted to show it in animation, where in KDB there was a clean scoop of the trabecular meshwork without any reflets, depicting the W sign in anterion. Whereas with Bang, since the needle was not made for that purpose, surrounding additive tissue injury could be, or the trabecular meshwork leaflets were not clearly removed, and that could be also a precursor for PAS. And this is another extension of the KDB cohort, which showed that results were more promising in the long-term follow-up as well, without any injury to the surrounding tissues. So this is the KDB image as well as Bang. So to conclude, IOP was comparable, AGM reduction was comparable, but the failure rate appeared to be double, and the proportion of the eyes to reduce 1 or more AGM while maintaining the IOP less than 21 appears to be greater in eyes with KDB compared to the Bang group. And future studies with RCTs are needed to have a much better conclusion. Thank you.
Dr. Prasanna, do you think this 6 months period of follow-up is sufficient to give any significant comments on this kind of a study?
Definitely, this is one of my studies I presented in the TNOA session last year, sir. Now I have a follow-up of 1.5 to 2 years, but I had to present the same slides. But the data that I have now with 1.5 to 2 years, again, those are pointing towards slight superiority of the KDB over Bang, especially when it comes to excisional goniotomy. So this was one of the earlier studies in mix when not much data was available, sir.
Thank you.
Thank you, sir.
We don't have to mark him, no?
So, Dr. Rashmi,
The next
we
one.
have to mark.
उसका कोई वो number नहीं है कोई. The next presentation, please. Dr. Shraddha is not here.
Dr. Shraddha is not there. Dr. Rashmi Krishnamurthy. Next is Dr. Krishnan. May I know your name, please?
Rashmi Krishnamurthy.
Please go ahead.
The slides, please.
Slides, please, for Dr. Rashmi. Dr. Shraddha is not there.
Yeah, good afternoon, everyone. So my study is titled Comparative Outcomes of Primary Congenital Trabeculotomy with Trabeculectomy in phacomatous pigmentovascularis versus Sturge-Weber syndrome.
So what is phacomatosis pigmentovascularis or PPV? It's associated with port vein stain and pigmentary nevi, whereas Sturge-Weber syndrome is associated with port vein stain and leptomeningeal angioma. So the basic difference is, though both are phacomatosis associated with port vein stain, leptomeningeal angioma with or without glaucoma, Sturge-Weber syndrome is usually unilateral, whereas phacomatosis pigmentovascularis is usually associated with dermal melanosis additionally, and it is often bilateral. The incidence of glaucoma is 30 to 70% in Sturge-Weber, whereas it has not been studied so far, and only one study suggests that it is 75% in PPV. So this is the surgical video showing after the limbal-based conjunctival excision, you can see the extensive vessels which are cauterized, and the Schlemm's canal is identified. 120 degrees trabeculotomy done with Harm's trabeculotome, and then trabeculectomy is continued. The deep ostium is excised, and surgical peripheral iridectomy is done, and the conjunctival closure is done. So experience of combined trabeculotomy with trabeculectomy in Sturge-Weber, it is around 80 to 100% success in our own study, but there are only few case reports or case series published on PPV, and the one from Dr. Mandal et al. Which says that it is around 80% at the end of 14 years. So though both are phacomatosis, the comparative outcomes between PPV and Sturge-Weber has not been studied. So this is the purpose of the study, to compare the outcomes of primary CTT in these children. So this is a retrospective study conducted on patients with early onset glaucoma in Sturge-Weber and phacomatosis pigmentovascularis who underwent CTT and with a minimal follow-up of 1 year. Diagnosis was primary clinical, and complete success was defined as when the IOP was more than 5 and less than 16 millimeters under general anesthesia and less than 21 in clinic with or without anti-glaucoma medication. Failure was defined as IOP beyond the above said range, IOP range, need for additional surgery, and loss of light perception, RD, and hypotonia. So coming to the results, 48 eyes of 32 children in PPV group and 49 eyes of 49 children in Sturge-Weber group were included. Though the majority of the baseline characteristics were comparable, age at presentation and age at glaucoma surgery, the epilepsy and abnormal MRI findings were higher in the PPV group. So coming to the postoperative outcomes, though the IOP outcomes were similar between the two groups, the need for additional AGM were higher in PPV group when compared to the Sturge-Weber group. So coming to the success, though qualified success was similar between the two groups, around 98% at 1 year and 93% at 5 years, the complete success was better in Sturge-Weber group compared to the phacomatosis pigmentovascularis group. And the complications also in Sturge-Weber group, majority of the complications were medically managed, especially the choroidal detachment. But in PPV group, complications like hemorrhagic CD, recurrent retinal detachment, phthisis was higher, and the need for repeat glaucoma surgery was also higher in PPV group. And the risk factors for failure of CTT were common, like age at presentation, corneal haze, and then higher cup disc ratio. These were the common risk factors between the two groups. Additionally, presence of anemia and presence of choroidal hemangioma were the additional risk factors in PPV group. So to summarize, CTT, though it's an effective option of managing early onset glaucoma in both the groups, in patients with PPV, it had less favorable outcomes with a greater need of additional interventions as well as greater need of additional AGMs. So it is important to have an individualized care for these patients, that there are distinct challenges posed by Sturge-Weber and phacomatosis pigmentovascularis, and it necessitates tailored management strategies. Thank you.
So any of your patients had any suprachoroidal hemorrhage and all that while you was doing surgery?
Not intra-op, they had during the post-operative period.
Because sometimes
Dr.
we need
Sonal
to use
Gupta, please come here. Sonal Gupta.
an AC maintainer when we are dealing with these patients. So I think when I saw your video, I didn't see any.
Yeah, so what we have observed is in late onset glaucoma, these complications are higher when compared to the congenital glaucoma in these children. So the onset of complications are lesser in these children.
So,
And in PPV patients, how many AGMs did they require once your surgery did not give the desired result.
The median of 1 to 2, median AGM of 1 and 1 to 2 was interquartile range of 1 and 2.
So the conclusion basically is that with CTT the prognosis is better in Sturge-Weber. That's it.
Sturge-Weber is better than
Better.
PPV.
So
yes.
that's your conclusion.
Yes,
That's
the success rates are better in Sturge-Weber syndrome.
Thank you so much, Dr. Sonal. Please go ahead.
Thank you.
Good morning, everyone. My topic is COX-1 and COX-2 gene as biomarker for initiating prostaglandin analog therapy in primary open-angle glaucoma. POAG is a progressive optic neuropathy with loss of ganglion cells and visual field deterioration in eyes with gonioscopically open angles with or without elevated intraocular pressure. In POAG, elevated IOP is a major risk factor that leads to optic nerve damage. Prostaglandin analogs are commonly used as a first-line therapy to lower the IOP. However, not all patients respond equally to PGAs, and there is a growing interest in identifying biomarkers to predict which individual will benefit most from this treatment. COX-1 and COX-2 gene enzymes are crucial in production of prostaglandin, which are involved in various physiological processes, including the regulation of IOP, and these are the rate-limiting enzymes that catalyze the formation of prostaglandin from arachidonic acid. COX is implicated in the production of prostaglandin that influence aqueous humor dynamics, potentially contributing to elevated IOP in POAG. It has been shown to be upregulated in various tissues of the eye, including the trabecular meshwork and ciliary body, where it may affect outflow resistance and IOP regulation. Variation or polymorphism in genes encoding COX-1 and COX-2 could influence the level of prostaglandin produced, affecting the response to PGA therapy. By identifying the specific genetic markers in COX-1 and COX-2, clinicians could predict which patient will experience a stronger therapeutic response to PGA. Drug treatment response has been studied in various other drugs like timolol with CYP2C1 gene and latanoprost, and also in AFPA gene in POAG patients. But no study has still been conducted showing the association of COX-1 and COX-2 polymorphism with drug treatment response of prostaglandin analogs. So it was a prospective observational study in which we took 106 eyes of 53 subjects of POAG patients. The history was taken and the IOP measurement, visual field analysis and OCT was done. Side by side, a peripheral blood sample of 2 ml was collected and genotypic assessment was done as well. After this, prostaglandin analog therapy was started and the follow-up of POAG subjects at 7th day, 14th day and 1 month was done. After this, the drug response was checked and the correlation of the maximum drug response to gene polymorphism was taken. Patients were classified as excellent responders, good responders and poor responders according to the percent IOP reduction. For genetic evaluation, DNA extraction was done by salting out DNA extraction method and was assessed during spectrophotometer quantification and analyzed on gel electrophoresis. COX-1 and COX-2 gene polymorphism was done in glaucoma patient via PCR, PCR-RFLP using specific primers and restriction enzymes. Coming to the results, this is the distribution according to the clinico-demographical profile of the study participants. Age of the patients enrolled in the study ranged from 41 to 70 years and the mean age was 55.08 with standard deviation of 8.84 years. Median age of the patient was 56 years and the majority of the patients were male. The family history of glaucoma was found in 33.96% of the patient. Majority of the eyes had moderate to severe glaucomatous field defects and advanced defects were observed in 18.9% and early defects only in 1.9% patients. This is the distribution according to the type of the treatment in which bimatoprost was given to 50 patients, travoprost to 32 and latanoprost to 24. This is a distribution of study participants according to the treatment response. Excellent responders were 61, good responders 39 and poor responders 6. This is a genotypic distribution of COX-1 and COX-2 gene polymorphism. Now the comparison of COX-1 polymorphism between the study groups for travoprost treated eyes. In this, we found that GG genotype of COX-1 was observed in significantly higher proportions of poor responders as compared to the excellent and good responders. Comparison of COX-1 polymorphism between study groups for latanoprost treated eyes. For latanoprost, AA genotype of COX-1 was observed in significantly higher proportion of good responders and GG genotype among excellent responders. G allele also showed a significant association with excellent response. Comparison of COX-2 polymorphism between study groups for bimatoprost. CC genotype of COX-2 polymorphism showed a significant association with good response. Comparison of COX-1 polymorphism between the study group for bimatoprost treated eyes. GG genotype of COX-1 polymorphism showed a significant association with good response. For COX-2, contrary to the findings of the present study, Lee et al. Found a CC genotype to be the most common in both the cases. For COX-1, contrary to the present study, Gong et al. Found the genotypic A to be dominant. On evaluation, COX-1 and COX-2 gene polymorphism with individual prostaglandin type, we found a significant association of COX-1 GG genotype with poor response. And COX-2 and COX-1 polymorphism GG genotype was associated with good or excellent response to bimatoprost. COX-1 polymorphism AA genotype was significantly associated with good and GG genotype with poor response to latanoprost. For conclusion, COX-1 and COX-2 genes hold a potential as biomarkers for initiating prostaglandin analog therapy, particularly by influencing the prostaglandin pathways that regulate the IOP. The present study for the first time has evaluated the role of SNP in COX-2 and COX-1 gene for response to the prostaglandin analog treatment in glaucoma patients. The findings of the present study is in general showed a weak but statistically significant association of COX-1 and COX-2 genotype. However, further research is needed to establish reliable and clinically applicable genetic markers before this approach can be widely adopted in clinical practice. Thank you.
How much is the cost of doing each genetic analysis?
Sir, for these number of patients, it costed me around 50,000 rupees.
50,000 for how many patients?
Sir, for 56 patients.
Huh?
56.
56.
So about 1,000 rupees
Yeah, we can say
per
that.
patient
Yes,
per
sir.
drug. So in case we have to do multiple drugs, then we'll have to do that also.
No, sir. For the only the genetic assessment requires the costing. So just we have to take a blood sample and do the genetic sampling of the patient. That would cost 1,000 only, no matter how many number of drugs has been used.
Okay.
No, so most of your cases were either moderate or severe, I think. So in any case, in these patients, one single drug alone might not control your IOP, and you might need multiple drugs. And as it is, when we start the treatment, we always give a 2-week trial of the therapy
Yes, ma'am.
before we add or we change
The
the drug.
yes, ma'am.
So how is this going to clinically help us? Because POG is not a condition which needs absolute emergency treatment.
Yes, ma'am. This is a futuristic approach to the glaucoma treatment. So basically, we are seeing because there is a growth in personalized medicine in our world right now. So if we can predict that this genetic variation is more helpful towards, for example, latanoprost or travoprost. So
Dr.
beforehand
Suraj
only-
is requested to come.
Yeah, continue.
Beforehand, we can already give the patient that particular type of drug beforehand, and we should not wait for another 2 weeks for the effect to show upon. So that's the major clinical implication. It is a futuristic approach for sure.
2 weeks is it that emergent for a open angle glaucoma, and that's what ma'am is asking. I mean, is it really going to be it's a nice study, absolutely a good study, but the practical issues and all, good.
Yes, sir.
No, otherwise it's a good study approach.
Thank you.
Okay, thanks. Thank you, ma'am.
So Dr. Suraj, please go ahead.
Good afternoon, everyone. Today I will be presenting our study on clinical morphology and AIOS2025-Free analysis of trabeculectomy blebs. Glaucoma is a progressive optic neuropathy where long-term IOP control is essential. Trabeculectomy remains the gold standard to achieve this goal. However, its success relies on the functionality and the longevity of the filtration bleb. Traditional slit lamp biomicroscopy offers limited insights, whereas AIOS2025 allows for a detailed structural evaluation of bleb morphology, enhancing our ability to predict surgical outcomes. So our study aimed to analyze trabeculectomy blebs both clinically and through AIOS2025. We classified blebs based on their morphology on slit lamp, evaluated their internal architecture on AIOS2025, and correlated these findings with IOP control and surgical outcomes. Additionally, we compared AIOS2025 findings with slit lamp assessments and analyzed early postoperative changes, including optical intensity of blebs using ImageJ software and impact of the interventions. This was a single-center prospective observational study conducted over 1.5 years, including 68 eyes of patients with POAG, PACG, and secondary glaucoma. These were our inclusion and exclusion criteria. Patient underwent standardized trabeculectomy with mitomycin C, and in some cases combined cataract surgery, both by single site as well as twin site techniques. We performed comprehensive ophthalmic evaluations, graded blebs using the Indiana Bleb Appearance Grading Scale, and conducted AIOS2025 imaging at 15 days, 1 month, and 3 months post-operatively. This is how the Indiana Bleb Appearance Grading Scale looks like, which was used for our morphological assessment on the slit lamp. As for the AIOS2025 analysis, with the patient looking down, Radial scans were taken through maximum point of elevation on the bleb as shown in the figure. The bleb wall reflectivity was classified as uniform reflectivity or multiform reflectivity depending on the presence or absence of hyper and hyporeflective areas in the bleb wall itself. The uniform reflectivity looked like smooth hyperreflective wall with no or minimal fluid-filled hyporeflective spaces within. The multiform reflectivity of the bleb indicated multiple tiny cavities of aqueous drainage like multiple internal layers, subconjunctival separation or presence of microcyst within the bleb wall. We calculated the bleb wall parameters such as total bleb height, bleb wall thickness and fluid-filled cavity height. The preoperative mean IOP was 23.29, while postoperatively the mean IOP at 15 days was 14.59, at 1 month 14, and at 3 months 13.41 millimeters of mercury. On clinical and AIOS2025 analysis, we observed that taller blebs were associated with better IOP control. Over time, bleb height decreased and wall thickness increased, which indicated maturation of the bleb. For reflectivity patterns, AIOS2025 revealed two types, the uniform reflectivity which was associated with higher IOP and lower filtration efficiency, and multiform reflectivity which indicated multiple drainage pathways and better IOP control. AIOS2025 demonstrated that multiform reflectivity was maintained in 92.9% of eyes following postoperative interventions, whereas untreated bleb showed a conversion to uniform reflectivity leading to a marginally higher IOP compared to the multiform group. This slide also shows the average optical intensity which progressively increased as the bleb matured. The bleb height gradually decreased, which indicated bleb maturation. The bleb wall thickness increased, which indicated stabilization of the bleb wall. And we noted that multiform reflectivity was a positive predictor of long-term success. Procedures such as 5FU injections, laser suturolysis, and bleb massage played a critical role in maintaining good bleb function. Our study highlights the importance of AIOS2025 in postoperative trabeculectomy assessment. Multiform reflectivity and taller blebs predict better IOP control. Early identification of bleb characteristics can guide timely interventions. Integrating AIOS2025 into routine follow-ups can optimize surgical success and reduce failure rates. So to conclude, AIOS2025 provides a superior method for evaluating trabeculectomy blebs compared to slit lamp examination alone. The recognition of key AIOS2025 features allows for tailored postoperative strategies to prevent bleb failures and to improve long-term outcomes. Thank you.
Dr. Aanchal Gera, please come on the dais.
How has your study clinically added to our knowledge about the existing knowledge about these features which are already well known on AIOS2025 and various bleb classifications? We already know what happens to these blebs on morphology on AIOS2025. So what additional knowledge have you added to us today?
Madam, I wouldn't say this is a very unique study, but of course in our study we have tried to integrate the clinical morphology with the AIOS2025 characteristics, and we have tried to identify those early AIOS2025 characteristics which could indicate impending bleb failure and the timing of the suitable interventions. So many of our patients have undergone variety of interventions, including 2 of them having gone bleb needling also. Of course, all of these clinical decisions can be taken on the clinical morphology basis alone, but then AIOS2025 gives us a more objective assessment, especially looking at that multiform reflectivity gives us a confidence that this is a kind of bleb which will survive in future.
Your study is only 3 months of follow-up, and it is said that almost 50% of the trabeculectomies fail over 5 years. Is there a predictor of long-term success that you can think of from your study?
No, sir. This is the most important limitation of our study, that it was conducted for only 3 months. We had targeted for at least 6 months, but we couldn't get a good follow-up, sir.
Okay, thank you.
Thank you, sir.
Dr. Aanchal Gera, please go ahead.
Thank you, sir. Good afternoon, everyone. Today I'll be discussing a study on comparison of bent ab-interno needle goniectomy versus goniotomy in PCG eyes. At the outset, I would like to declare that this study was recently published in Ophthalmology Glaucoma in the fag end of December last year. So in our study, as we all know, primary congenital glaucoma is a primary developmental anomaly of the trabecular meshwork, and the mainstay of treatment is surgical intervention. So surgical intervention is determined by the corneal clarity If the cornea is clear, then we go ahead with ab interno procedures such as goniotomy. And when the angle is not visible, then we go ahead with ab externo procedures. So goniotomy was the first angle surgery described by Barkin, and it basically enhances aqueous humor outflow by incising the trabecular meshwork. And the surgical success that we know at around 1 year is 60 to 80% in various studies. And BANG stands for bent ab interno needle goniectomy, which is a variation of Barkin's technique given by Shute, and it uses a bent 25 needle reverse cystotome, which excises the trabecular meshwork instead. So we had a study research question: will the stripping of trabecular meshwork offer any additional benefit over simply incising the tissue in infantile PCG eyes? For this, we did a study to evaluate the efficacy of BANG compared to the established standard of traditional goniotomy. Our study was a prospective interventional parallel group randomized controlled trial in which we included infants with bilateral symmetrical PCG with an onset of glaucoma in 1 month and 1 year of age, with no prior history of ocular surgery and a corneal clarity grading of less than 2. One eye of each infant was randomly assigned either to goniotomy or BANG with a 1:1 computer-generated randomization, and the outcome measures were IOP control and the requirement of anti-glaucoma medications. Secondary outcome measures were complications of surgery and the requirement of additional surgery. Complete success was if intraocular pressure of less than 18 was maintained without medication, and qualified if maintained up to over 2 medications. Failure if more than 2 medications were required or a resurgery was required. The baseline characteristics of goniotomy and BANG of each eye were comparable for these parameters, which were assessed: corneal diameter, mean corneal clarity grade, axial length, intraocular pressure, cup-disc ratio, central corneal thickness, baseline number of medications, and mean degrees of angle treated. All of these were statistically similar in both the eyes. Outcomes were measured at 3 months, 6 months, and 1 year of duration. The intraocular pressure at the outset was 24 and 25.5 in the goniotomy and BANG group respectively, and at the end of 1 year, we can see that it had decreased to 15.3 and 17.1, but both of them were statistically similar at all the follow-ups. Similarly, for the number of anti-glaucoma medications, at the beginning it was 1.7 and 2 in the goniotomy and the BANG group, and at 1 year of follow-up, it had decreased to 1.14 and 1.28 with no statistical difference at any standpoint. This graph summarizes the entire study, in which we can see that the line diagrams are showing the degrees of angle treated for each eye in the BANG group and the goniotomy group, and the extent of angle treated was similar in both the eyes of each patient. And for all the patients, the bar grams are determining the pre-intervention IOP and the post-intervention IOP. And we can see in the goniotomy group, 3 eyes were medication-free at 1 year, which was a complete success. 4 eyes were qualified success, and 1 had failed at 1 year follow-up. 2 BANG eyes were medication-free at 1 year, 4 were qualified success, and 2 had failed in the BANG group. Hyphema was the only complication noted in the goniotomy group. 2 eyes had hyphema, which resolved within 2 weeks, and BANG group at 3 eyes had hyphema, which resolved again within 2 weeks without any intervention. So we could demonstrate comparable success in both the groups, and added complexity of excising the meshwork did not confer any additional benefit in the PCG eyes. We can say that the IOP lowering effect may be attributed to the angle widening and falling back of the highly inserted peripheral iris, regardless of the amount of trabecular meshwork tissue removed. Our study is limited by small sample size, but it had a stringent study design, and we can confer that goniotomy remains a reasonable surgical procedure in PCG eyes. Thank you.
Thank you. Do you think with such a small sample size, can we draw any clinically useful inference from this study?
So because the eyes were exactly similar in all of the parameters, such as intraocular pressure was less than 3 millimeter difference, and axial length of less than 1.5 millimeter difference between each eye of each patient, and cup-disc ratio of less than 0.2 difference between each eye of each patient. So we know that both the eyes were very, very similar in the parameters that were being assessed. So even though the sample size is small, I agree on that, but the result then becomes significant.
Okay. Any question?
The complication rates were nearly similar, right?
Yes, sir.
Okay.
So how long was your follow-up?
Ma'am, 1 year.
1 year.
We're currently doing a 2-year follow. We'll be publishing the results soon, ma'am.
Please go ahead.
Okay. Good afternoon. My paper is on impact of contrast sensitivity on visual quality in different types and stages of glaucoma. Coming to the introduction, glaucoma affects over 70 million people worldwide, which is the second most common cause of blindness. It is a group of disease causing progressive irreversible optic neuropathy and leads to degeneration of retinal ganglion cells and loss of the visual field. Early detection and prevention are key to reducing the progression, and the techniques for detecting visual field changes are vital in the glaucoma management. Visual field changes are crucial markers for disease progression and improvement. Goal of the treatment is to preserve the visual function. Contrast sensitivity function is in early glaucoma patients may experience compromised visual quality despite a good visual acuity. Contrast sensitivity is the ability to perceive sharp and clear outlines of very small objects. It is also defined as the ability to perceive minor illuminance changes between the interspread regions not separated by defined borders. My aim is the impact of contrast sensitivity on visual quality in different types and stages of glaucoma. It is assessed using Snellen's visual acuity chart, Pelly-Robson contrast sensitivity chart, and Humphrey visual field analyzer. The study population, after obtaining the ethical committee clearance, people diagnosed with glaucoma who come under the inclusion criteria were taken up for the study. It is a cross-sectional study, sample size is 41, and the time frame is 1 to 1 year, 3 months. The inclusion criteria, all patients with diagnosis of glaucoma, glaucoma suspects, normal tension glaucoma, ocular hypertension, patients with visual acuity 612 or better. Exclusion criteria, cataract, posterior capsular opacification, patients with pathological myopia, media opacities, diabetic retinopathy, age-related macular degeneration, and any other retinal pathologies were excluded. Visual acuity was recorded in logMAR values. Contrast sensitivity measured at 1 meter difference using Pelly-Robson charts. Evaluation included Goldman tonometry, gonioscopy, slit lamp biomicroscopy for the anterior segment, and optic disc inspection using an 90D lens. Glaucoma type and severity were determined using slit lamp biomicroscopy and indirect ophthalmoscopy, post-pupil dilatation. HFA 24-2 CETA standard program was used in visual field analysis and categorized into mild, moderate, and severe. The results, the study population involved 41 patients, predominantly age group of 51 to 60, with slightly more male predominance, 56.1%. Visual acuity varied with the best recorded as 0.3 in both eyes. Mean intraocular pressure was 24.71 in the right eye and 17.71 in the left eye. HFA mean deviations were minus 10.61 and minus 8.3. This is the graph showing the distribution of subjects according to the type of glaucoma, in which normal primary open angiography was the most common type, followed by normal tension glaucoma. Correlations of right eye HFA and CS score shows a positive correlation between the right eye HFA and the right eye contrast sensitivity score, which was statistically significant. And comparing the left eye HFA and CS score, it also shows a positive correlation between the left eye HFA and left eye contrast sensitivity score, which was statistically significant. The scatter plot showing correlation of left eye HFA and logMAR score shows a negative correlation between the two. And the scatter plot showing correlation of right eye HFA and logMAR score also shows a negative correlation between the two. The discussion, right eye mean deviation and right eye contrast sensitivity score has a positive correlation with a p of less than 0.001, and significant relation between visual field loss and contrast sensitivity was seen. Left eye mean deviation and left eye contrast sensitivity scores shows a moderate positive correlation. These were consistent with the studies done by Suhail et al., which was conducted over a period of 8 weeks using a home-based contrast sensitivity testing chart. The results proved a positive correlation between the two, which was consistent with the findings of our study. Another contrasting study done by J. Yong Yang and Yun-Ji Lee study on contrast sensitivity in glaucoma patients. Contrary to the previous assumptions, their findings suggest that the contrast sensitivity does not necessarily correspond to the location of the visual field damage in glaucoma patients. Instead, they observed that the contrast sensitivity was most significantly affected in patients with severe visual field damage, irrespective of the location of the defect. Visual acuity and visual field loss shows a moderate negative correlation in both the eyes. Concluding, correlation analysis conducted in our study revealed important relation between key visual parameters. We observed a negative correlation between the increased logMAR score and mean deviation score, but a positive correlation was found between the decreased contrast sensitivity score and mean deviation score. Eye disorders such as cataracts and other ocular conditions such as retinopathy, age-related and diabetic maculopathy were excluded. These correlations indicate the interdependence of visual acuity, contrast sensitivity, and visual field sensitive in glaucoma assessment.
Did you include the cases, the glaucoma suspects also in this study?
Yes, sir.
But that is not a stage of glaucoma. It's only a vague terminology. It's our limitation of knowledge. That's it.
Yes, sir. But
Your title says impact of contrast sensitivity visual outcome in different types of and stages of glaucoma.
Yes,
it's
sir,
not a stage of glaucoma.
Sir, even though that was considered as an inclusion criteria, none of the patients were
That I could see in the study, but why was it included? So this is absolutely actually not acceptable as a inclusion criteria, and then not including those cases. Neither.
Like ocular hypertensive patients.
Yes, ma'am.
No, glaucoma suspects, you are writing in the inclusion criteria, you are not including them, and then you are not, it is not there in the title also. So this I think if you present it somewhere else also, then this has to be rectified. Chal. Dr. Vinita, please come. In fact, all the cases, all these papers have been so good today. I'm sure because after compilation, the scientific committee team will have a lot of issues in finalizing who is the best, because all of them are best. There have been some limitation only in 1 or 2 papers, but even they were ignorable, but most of the papers were very, very good today. And after she finishes, I request all the presenters and including the co-authors who are present here to come here for a photograph, so that we don't waste time. We are already running short of time. Please go ahead.
Slides. Not loaded.
Slides, okay. हाँ कर.
आज मॉर्निंग में लोड किया
मार्क कर देंगे ना, वो अपने आप निकाल देगा. सोसाइटी से जो पेपर्स होते हैं ना, जो वहाँ सोसाइटी में टॉप करते हैं. अच्छा, they are presented here. वो they are presented here. हमको आने जाने का खर्चा भी मिलता है. ठीक है, ओके.
Very good afternoon to one and all. This paper was presented in Telangana last year. I updated the data, and to my surprise, the results hold even after 1 year of surgery. So minimally invasive glaucoma surgery are procedures and devices, not just one surgery, which are usually with small incisions and blebless. Can be categorized in many, many ways, but what I like to see it as a outflow procedures and inflow procedures. Inflow meaning reducing the aqueous, outflow, there are several procedures. What the good thing about MIGS is that it utilizes natural physiological pathways like the trabecular meshwork, like the ciliary process, and the suprachoroidal space. The outflow pathways, they are said to open up dormant collector channels, especially in the infranasal area. This is limited by the episcleral venous pressure, and so very low IOP, it is said, cannot be achieved. And so it is effective only in early disease. So I set about to investigate the safety and efficacy of combining outflow and inflow MIGS procedures with phacosurgery in advanced primary glaucomas, and compared it with the current gold standard of phacotrabeculectomy. This is a retrospective study in advanced primary glaucomas who underwent either combined MIGS procedure or TRAB MMC along with phacosurgery. Primary outcome measure was IOP greater than 5, less than equal to 15 millimeter mercury, and secondary were anti-glaucoma medication, total success, complications, and interventions. The combined mixed procedure was all done under subtenon's anesthesia, sterile conditions. First, temporal paracentesis was done, and the patient was positioned, so was the microscope, and under intraoperative gonioscopy, the KDB was done, followed by phaco in normal position, and then after placement of the IOL in the bag, the endoscope was introduced into the sulcus, and as you see, ECP was done. Where phaco-trab is concerned, I did all under injected mitomycin C. They were then shifted to the OR, and they were mostly topical surgeries with usage of non-preserved lidocaine during surgery. I did superior site, separate phaco and trab. First, a rectangular flap was raised, then a clear corneal phaco was done adjacent to it, which was then sutured, and then trab was completed. The preoperative characteristics were pretty similar in both the groups, except where the IOP was concerned. It was slightly higher in the phaco-trab group, and preoperative visual acuity, which was better, slightly better, in the combined mixed group. Both procedures were very effective in reduction of IOP and anti-glaucoma medication and improvement of visual acuity. But when we compared between groups, what I found was the combined mixed group actually had slightly lower IOP with lesser standard deviation compared to phacotrabeculectomy, though this difference was not statistically significant. Anti-glaucoma medication also was slightly lower in the combined mixed group, but this too was not statistically significant. What was statistically significant was the difference in the recovery of vision. It was better in the combined mixed group. Complete success was no different between the groups. However, total success was better in the combined mixed group. Failure rate much higher in the phaco-trab group. So was the serious complications defined as sight-threatening complications as well as visual acuity worse by more than 2 lines. Interventions also much higher in the phaco-trab group. So combined mix is combining inflow and outflow. It seems to have an additive synergistic effect akin to combination anti-glaucoma medications that we commonly use in our practice. It can achieve a low target IOP in a safe manner. Role of episcleral venous pressure, including that of the collector channels, still remains to be answered. So combining inflow-outflow mix is in the least non-inferior to the current gold standard. It is safer, it has better preservation of vision, avoids all BREB-related issues with lesser number of post-operative interventions. Of course, larger studies and longer follow-up are recommended. Thank you very much.
How much was the average follow-up in your cases?
12 months. 12 months.
12 months, okay.
1 year.
1 year, I think, is too less to come to any conclusion. So long-term studies would be required.
Yeah, that's the last line of my slide.
Yeah.
Thank you.
So I think in a person who is basically one-eyed advanced glaucoma, maybe this option would be better than going in for an filtering surgery like a phaco-trab. I think that would be a good idea to try these, or at least on one-eyed
All the
patients.
presenters, please come on the dais for a photograph. You continue, please. Dr. Kiran, you continue, please.
No, that's what
Including
I
the
felt
co-authors. Co-authors can also join in for a photograph.
because if the results are equivocal, then for one-eyed patients, having a MIGS along with cataract might work better in advanced cases where a loss of...
Yes, madam, but you have to combine two. Just single one is probably not sufficient. And of course, it's much safer. Much
That is
safer.
the point that we come. Come join us.
Vinita, and thank you all the presenters. Just we'll have a photograph, and I'm sorry from the next people, we are delayed a bit. We got the hall also a little late.